how this has always worked for centuries and eons. But the system, internally generated system, is involved in mood, pain, memory, and appetite. The name is unfortunate because it implies it evolved from the marijuana plant. It didn't evolve. The system evolved in humans first, and then certain chemicals in the plant were found that could mimic naturally occurring chemicals that are binding to these receptors. So it's really important to understand that. All right. So what do CB1 agents do that stimulate CB1? Well, it inhibits basal ganglia dopamine release. Well, I thought we want more dopamine. Well, yes, we do. So CB1 agonists actually inhibit the release of dopamine and therefore would be expected to be ineffective in alleviating Parkinson motor symptoms. And this has been shown in monkeys. It slows monkeys down, worsens their bradykinesia. But it has been shown to improve some motor impairments, not necessarily slowness, possibly through another system, which we don't yet understand. Now, agents that block or inhibit CB1 are more consistent in improving motor symptoms in Parkinson's without increasing dyskinesia. So CBD is an agonist. CBD isn't an antagonist, so it falls within the top where it would be expected not to help Parkinson's symptoms. But let's look at some studies. Well, there have been 4 controlled studies using cannabinoids. No benefit in slowness or tremor. Well, you shouldn't be surprised. It inhibits dopamine release, so why would it be? There have been mixed results in their ability to improve the extra twisting movements called dyskinesia. So mixed results, not consistently positive. So what can we say? Well, CBD and cannabinoid agonists and antagonists are probably ineffective for both motor symptoms and dyskinesias, but maybe dyskinesias, but definitely not the motor symptoms. So perhaps future studies that look at this might want to look at different doses, different formulations, or just try to improve certain symptoms in Parkinson's, like the contraction of muscle, hallucinations, or sleep because of the involvement in those areas normally. So, important to recognize those results. How about other movement disorders? I promised we'd talk about something other than Parkinson's disease. So, it's been looked at in Huntington's disease, 2 controlled studies, one no effect, the other some motor improvements. In dystonia, both studies no benefit. In patients who have Tourette's syndrome, 2 small studies did show some improvement in tics, which might be expected because tics are an extra movement like dyskinesias. And it also helped obsessive compulsive behaviors, which sometimes are a problem in Parkinson patients, specifically those on dopamine agonists. So something to consider. Now, I will tell you that there are a number of approved therapies on the market. As early as 1985, these were placed in the market, some that are THC analogs, some that are plant-derived. They've been approved for use of chemotherapy-related nausea and vomiting, AIDS-related loss of weight, and more recently, in 2010, an approval of a drug called Sativex for pain and spasticity in multiple sclerosis, not in the United States, but one in the United States just last year was approved for a certain very rare form of epilepsy seizure disorder in children called Dravet and Lennox-Gastaut syndrome. So there are some approved therapies, but nothing for Parkinson's disease. Well, what about safety? We always want to know the benefits, but what about safety? Well, side effects in the studies have ranged from 7 to 10% in patients, and primarily have been balance problems, nausea, trouble thinking, even suicidal ideations, hallucinations. These are across the studies for the approved drugs now. Dizziness, fatigue, impaired motor skills, which were not a surprise. Now, what are the side effects that have been reported for smoking marijuana? Increased risk of chronic anxiety, depression, psychosis, perhaps an increased risk of lung cancer, although the causality of these cases of lung cancer have not been established. And it has been considered a gateway drug and has an abuse potential of approximately 10%. So, things to keep in mind. So, some unknown issues about safety. We don't know anything about long-term risks. Cannabinoids are deposited in fatty tissue, so those long-term deposits can have an effect long-term that we don't know. Well, the use of marijuana, cannabis, is generally safe in overdose. There have been some illicit synthetic cannabinoids on the market that have been associated with severe medical and psychiatric complications. And what you can get over the counter, you don't know what it is. I don't know what it is, and the FDA doesn't know what it is. So you have to be very careful. And as I said, sometimes it can be a gateway drug. We don't know the effects on fetuses, so use in pregnancy is not known. And we don't know the effects on driving. And so, what's the summary of this section? Well, compounds from the marijuana plant are known to interact with the central nervous system, including regions affected in Parkinson's disease. But there are no studies that have proven the benefits for Parkinson's disease or other movement disorders. And so any use has to be tempered not only with placebo-controlled studies, because we know how great placebo is, versus the actual drug itself. And I showed this last slide. This was a report done by the FDA. You can find this on the FDA website. When they surveyed the various CBD oils out on the market, they found 5 that had no CBD in them. So not only is it not useful, it doesn't have any in it. So you have to be very careful about utilizing this product in its present form. So, all right. Hopefully, I've answered that question. All right, we're going to do a short question session before we get into the next Doctor What About. So, any questions?
Yes, here.
Where are we?
To your left.
Hello?
Okay.
Hello? I have a question. I have been on Levodopa, carbidopa now for about 3 years. When it was first prescribed to me, I went to the pharmacy, picked up the bottle, looked at it, it said take 1 or 3 times, or 2, 3 times a day with meals. And I've had several discussions with other Parkinson's patients, and everyone has had a different answer as to, do you take it with the food, an hour before, an hour after? That's what I'm asking you.
So the question is, how should you take levodopa in relationship to meals or food? And so the reason that it sometimes is stated to take it with food is because in some patients it produces nausea. And so sometimes food on the stomach will lessen the nausea. But usually the nausea is due to the fact you don't have enough carbidopa on board. So if you have nausea and you don't have the ups and downs, taking it at the same time as your meals is probably not an issue. Now, once the medication starts having the wearing off, where a dose takes longer to kick in, or it doesn't kick in, or it wears off, then you're going to want it to get to that first part of the intestine without the complication of food in the stomach, slowing the stomach down, because remember the pill has to get through the stomach, and if there's food in the stomach, the stomach has to break down the food. And that takes time. And so if your pill is sitting amongst that mush, then it's not going to get into the intestine very quickly. Certain foods slow the gut down even more. Fatty foods high in fat slow the stomach down because they're more complex to break down. So in patients who have ups and downs, we generally would like them to take their levodopa 30 minutes or longer before they eat. Now, if you're taking it every 2 hours, then that becomes a problem. And so then in those cases, like we heard earlier, you want to graze eating small meals throughout the day so that you never have a large amount in the stomach that is going to impede the levodopa to get to that first part of the intestine. Okay, next question.
What can you tell me about Rotari?
So the question is about Rotari.
Yes.
So Rotari is levodopa. It is a mixture of immediate and long-acting levodopa in a capsule. So the capsule is taken, usually 3 capsules 3 times a day, and it has been shown to be effective in lessening those ups and downs. Now, you have to be on the right dose. So sometimes converting from regular levodopa to Rotari, there is a time of dose adjustment. And so if it doesn't work very well in the beginning, it's likely that the conversion to the dose of Rotari wasn't sufficient. Another question.
Is there any benefit to oxygen therapy?
Dr. Alvarez.
I'm
Question is
sorry.
oxygen therapy.
Yeah, I don't think we have, it's just like CBD, I don't think we have enough data to support that. I'm not sure if there's any other literature or studies that you've encountered.
Yeah, not for the primary symptoms of Parkinson's disease. Next question.
Get something next. As to revisit one of your sessions a while ago, and just now the question regarding Rytary. And before Rytary, taking levodopa in different forms, as one increases the dosage of those drugs, you haven't mentioned much about the dyskinesia. I mean, you did mention it a few times, but I would have thought it didn't mention more here today. And wondering, what is it not the sequential thing that's going to happen to one by increasing the drugs over a longer period of time, and so forth?
Right, so there are 2 issues. So one is taking larger doses leading to the occurrence of dyskinesias. And we've said that while there is no evidence that levodopa hastens progression, higher doses have been associated with the earlier occurrence of the ups and downs and dyskinesias. Again, the reason that we would like to stay 400 to 600 milligrams in general, okay, depending on the patient. So there can be an increased risk for the occurrence with higher doses. Then once you have dyskinesias, they occur when the dose necessarily, usually in most patients, are peaking. So the peak effect of each dose. Some patients can get dyskinesias when the dose is kicking in and wearing off. Those are generally in the legs only. But the typical dyskinesias occur at the peak of each of the doses. And so sometimes we'll have to lessen each individual dose that's associated with the dyskinesia, but maybe give it a little more frequently. So, and other options are using amantadine that is specifically approved to treat dyskinesias. Another approach is adding another agent and lowering the levodopa dose. Another approach is considering deep brain stimulation for treatment of motor fluctuations of dyskinesias.
Dr. Packard, we have 2 questions over here. One is, when you take your levodopa sublingually, do you see an effect faster?
Yeah. So where does levodopa get absorbed? In the first part of the intestine, right? So putting it under your tongue and thinking it's going to get to the intestine faster, there is no data that that is effective. And in fact, there is a study that compared the 2. There's no difference. Now, is there a placebo response? Well, yeah, maybe. And so if that helps the patient, well, then great. Levodopa is not absorbed anywhere except in the first part of the intestine and the lungs. We now have an inhalational form, but it is not absorbed in the sublingual space.
The second question is about Azelac and hair loss. Could the Azelac be causing hair loss, particularly around the face and ears?
Yeah, that I haven't heard. I don't know if anyone will know. Yeah. So I would investigate other potential causes before I blame it on the Azelac.
We have a question.
Okay, so we're going to go into the next. We'll get back to the question. So again, the next topic, doctor, what about? So our topic now is stem cell